though I'm at a very, very cold place right now. The temperature outside is 0. But still a warm welcome. And we have two chairpersons who will be gracing the occasion. And we have our President of Indian Association of Biological Psychiatry, that is Dr. Sunil Mittal. He is a well-known psychiatrist of India, and I would say that he is an inspiration for me as well. Met him around 2 decades ago in Delhi for the first time in 2004, 2005. In addition, he has more than 40 years of experience as a consultant psychiatrist. He has done his MD from PGI Chandigarh, if I'm correct. He has a lot of feathers in his cap, and he is former president of Indian Association of Private Psychiatry as well as Delhi Psychiatric Society. He is the chief mentor at the Cosmos Institute of Mental Health and Behavioral Sciences in Delhi. Dr. Mittal has been engaged actively with the press and media to create awareness about mental health issues and to debate on related policy matters. This is just a small introduction about Dr. Mittal. I think he is much, I would say that it will take me half an hour and the program will go into that if I keep on introducing him. And second important chairperson that we have is Dr. Purnima Nagaraja, who is a consultant psychiatrist in Drithi Wellness Clinic, Hyderabad. She's an experienced psychiatrist with a demonstrated history of working in the hospital and healthcare industry. She skilled in psychological assessment, special needs, rehabilitation in children and adolescents, personality development, healthcare, cognitive behavioral therapy, women empowerment, child abuse support and counseling, training and psychological wellness. An experienced teacher who teaches psychiatry, psychology, and mental health at the undergrad and postgrad and even at doctoral level. Consulting professional with a diploma in psychiatry, MS in psychotherapy, focused in psychiatric psychology, assessment, rehabilitation, empowerment, and mental health from Siddhartha Medical College. May I request both the chairpersons, one could introduce the topic and other could introduce our speaker and moderator, and then we are good to go ahead with the presentation of the speaker. Over to chairpersons.
Right. Well, thank you, Bajit. So I make a few opening remarks, and then of course my co-chair would take over. And in case you have the details, perhaps you could also introduce the speakers and the moderator. The speaker and the moderator. Yes. So pain is, when I read this topic, I was really impressed because pain is a 4-letter word, and it is more than, like has been said, a 4-letter word, and it's integral to human experience, our life, our existence. And I think it's without pain we would have ceased to exist. But yet it can be painful. It can hurt. Of course, one can talk about the hurt and pain of love, of heartbreak, but also at the same time the acute and chronic dimensions of pain. The acute pain, chronic pain, whether it's and then it has the psychobiological aspects, the neurobiological aspects, the whole biopsychosocial. You can view it anyway. There are pain specialists, but as psychiatrists, we see pain all the time. It's whether it's emotional component or it's the chronic pain that we see. People with vulnerabilities, whether anxiety or depressed, or pain causing anxiety and depression, and often dismissed when it's chronic, by other people and other specialists. People with chronic pain may not get audience with a doctor, may not actually be seen well by a doctor. So we don't have a painometer, so we can't measure what degree of pain there is. But of course, there can be some measures. And having said this, then of course, we have the whole issue of the nociceptor pain, the neuropathic pain, the centralized pain, and the something that eludes all of us, but a lot of work has been done giving it, insights, the phantom limb pain. So there's a huge dimension, and the areas in the brain that may be involved, the correct me if I'm wrong, the periaqueductal gray part in the midbrain, the medullary reticular system, the raphe nucleus, and of course, then you have other areas like the locus ceruleus and so many brain areas involved. The ascending pathways for perception, the descending pathways for control. But we have an expert here who's going to speak about it. So with this introductory remark, I hand over to my co-chair, to Dr. Poonam, to speak further and take this forward.
Thank you, Dr. Mittal. Hello, everybody. And I've been given the onerous duty of introducing both the speaker and our moderator for today. So let me start with the speaker. So our speaker for today is Dr. Kiran Shandilya. She's done her MBBS, MD, and DPM, and she's a psychiatrist at Kiran Mind Center in Mumbai. Her specialization and areas of interest would be she's a psychiatrist, a psychotherapist, and a neuropsychiatrist. She's from the Armed Force Medical College. She's done her master's in from Grant Medical College, and of course, Sir J.J. Hospital. And she has been a psychiatrist since April 2008. And between June 2008 and 10, she was an assistant professor at JJ Group of Hospitals. And thank you for being here, Dr. Kiran. And we hope to hear some revelations, painful revelations about this thing called pain. See, it's very difficult to quantify pain, because what is pain to me may not be pain to you at all. And there's a lot of mental process that is, that is involved in this whole thing of pain appreciation and pain perception. So we are looking forward to hearing from you about all of this, and we hope it's going to be as enlightening as you promised it to be. And next, I would be introducing Dr. Manu Tiwari, who is a distinguished psychiatrist from Delhi. He's the HOD and a senior psychiatrist in Fortis, Noida. And he's a practicing consultant psychiatry, completed MBBS from Maharashtra, and finished his post-graduation psychiatry as a top ranker from a prestigious Mumbai university. Also conducted international trials in adolescent schizophrenia and depression. Dr. Tiwari also received the international certificates for MINI, AMD, and MADRS rating scales. He's a life member of the Indian Psychiatric Society. He has attended and presented in various places and levels. He also participated and received an award for his services in for the flood affected people, and he is he also was very responsible in getting the and instrumental in getting the ISO 9001 to 2000 certificate for Department of Psychiatry in TN Medical College, Mumbai. So he's been a senior resident. He's been so many things, donned many hats, and still continues to do so. Welcome, Dr. Manu Tiwari. It's a pleasure to have you here, sir. And I think I would be doing a great disservice if I didn't talk about Dr. Abdul Majid, who's introduced this program. So he's been the professor and head of psychiatry of the government SKIMS Medical College. He was the head honcho who organized the MidSIPS 2013, and I missed that, unfortunately. And he also organized multiple events for the IPS. He is a national. He has got the National Award for Excellence in Mental Health, the Shweta Tiwari Memorial Award, the GC Boral Award, and the International Distinguished Fellowship of the American Psychiatric Association. He has been associate editor for the Journal of Geriatric Medicine, Aging Psychiatry, the Frontiers of Psychiatry, Archives of Biological Psychiatry, Journal of Mental Health and Substance Abuse, Journal of Mental Health and Human Behavior, and the Journal of the SARC Psychiatric Federation. He has got more than 100 papers to his credit and lots more. So thank you, Dr. Majid, for introducing the program to all of us. And over to you, Dr. Manu Tiwari, to moderate this show.
Thank you, ma'am. So without wasting any further time, I invite Dr. Kiran to enlighten us about the various aspects of pain, and then we'll take on the questions from the audiences, or we'll have a brighter discussion after that. So over to you, Dr. Kiran, please.
Thank you so much, sir. And thank you, ma'am, for your time.
Your voice isn't very clear, Dr. Kiran.
It's not so clear. Hello?
Now
Is it better now?
Now it's fine.
Better now?
Yes.
Yes.
Okay. Is my slide visible?
Yes, it is.
Yes, it is.
So pain is a four-letter word because it is such a sticky diagnosis. I think 1/3 of any patient visiting any doctor, forget a psychiatrist, is complaining of pain, specifically chronic pain. Chronic pain is so sticky that the doctor changes, the focus of diagnosis changes, our focus of investigation changes, the approach to medication changes, but the pain stays. And over a period of time, the patient, because of his selective perspective, which is encompassed by pain, his narrative of his life, his self-identity becomes pain. So, and of course, it's very frustrating to the doctor to keep seeing the same patient back and back again who keeps saying, "Koi farak nahi pada, doctor, kuch farak nahi." So, let's start with a conceptual understanding of pain. Dr. Rukshida asked me to speak on this topic, and I thank her for that. Also, because we speak on these topics, we'll end up studying for ourselves also. She has also told me very specifically to stick to the biological aspect. That is what I'm going to try and do in the next 30 minutes. So Marcia Agner said that few things a doctor does are more important than relieving pain. Pain is soul destroying. No patient should have to endure intense pain unnecessarily. The quality of mercy is essential to practice of medicine. Here of all places, it should not be strained. So with that quote, so let's understand there's a difference between an acute and a chronic pain. In acute pain, it's a very useful pain because what happens is that probably the place requires immobilization. So you will not move your thing so that it can heal better. So acute pain may have some form of central sensitization which improves with healing of injury. But in chronic pain, central sensitization, irrespective of whether the pain was of peripheral origin or central origin, continues to happen. There is sensitization in the absence of ongoing injury. In acute neuropathic pain, uh, sorry, so acute pain, commonly chronic pain is neuropathic in origin, and nociceptive pain is more commonly acute. So let's see this more. This is what I think Dr. Mittal was referring to, and also Dr. Majid was referring to. That what we talk of pain is probably a lot of these symptoms that are coming in between. There is depression, there is anxiety. There is not one thing that can touch the body and leave the mind untouched. And the reverse is also true. There is not one thing that will touch the mind and have no scar. So, and as psychiatrists, we see day in and day out. So there are three major categories of pain: the nociceptive, the neuropathic, and the sensory hypersensitive. Nociceptive pain is actually related to tissue damage at a peripheral, somatic, or a visceral tissue damage. Examples are rheumatoid arthritis, gout, etc. Neuropathic pain may be related to damage of peripheral nerves or central nerves. We can have diabetic neuropathy or post-herpetic neuralgia. And we have sensory hypersensitivity, where there is no identifiable nerve or tissue damage like fibromyalgia. So this is just a revision from our first MBBS anatomy days. The pain is carried through, so there are two major kinds of pain. There is a delta fiber that carries pain. It is a myelinated fiber, fast-moving fiber that carries mechanical stimulus. And C fiber, which is a slow unmyelinated fiber that carries heat and chemicals. All of them go through the dorsal root ganglion, and then they go through the spinothalamic. So this is how pain is carried up to the cortex and perceived. At the level of injury, at the peripheral site of injury, the receptors catch the signal. The signal is transducted, carried to the dorsal root ganglion and to the spinal cord. This process is called transmission. The signal is carried up to the thalamus, and where the perception of pain beyond thalamus at the level of cortex And there are a lot of inputs from various areas like the reticular activating system, the limbic nuclei, the periaqueductal, even amygdala, the emotional centers of the brain. And all these modulate the perception of the pain. Other than that, there is a descending pathway that acts in modulating and inhibiting the pain. And most of what we use works on the descending pathway. We can have pro nociceptive influences and anti-nociceptive influences. And like I said, there are so many areas, like the limbic forebrain areas. So, for example, let us say I'm going for a and I banged my head somewhere. Chances of that pain being centrally sensitized are far less than, let us say, somebody who's going through domestic violence and her head is banged to the wall. Chances of that being centrally sensitized are a lot because it carries correlate. So some areas of the brain, periaqueductal way, all of them are pro-nociceptive. Again, central pain perception is something where the spinal thalamic tract carries through the thalamus, and from thalamus there are projections that are acting through limbic structures, through the cortex, our understanding of pain. For example, our understanding of pain, which we go through, like let us say a vaccine, I have to go through, is very different from a pain which is emotionally unwanted. There are these various neurotransmitters that influence pain. So substances that promote pain, substance P, glutamate, nerve growth factor, serotonin, and that inhibit pain transmission are norepinephrine and serotonin, 5-HT1A receptor specificity, opioids, cannabinoids, GABA. So they all tend to reduce pain. So let's look at the various drugs where they act. At the level of transduction, transduction is where the receptor, the nociceptive receptors are there in the first perceiving pain. At this very level, our NSAIDs will act as inflammation, antihistaminic, opioids, and local anesthetic, topical local anesthetics will act. When this is carried to the dorsal root ganglion at the level of transmission, local anesthetics like nerve blocks and opioids act. At the level of ascending pathway and descending pathway both, where the modulation of pain happens, again opioids act. At this level, NMDA receptors may also act. And at the cerebral cortex level, we may have other modulators like serotonin, but again, opioids. So the case I'm trying to make is that why opioids are so strong in management of pain is that they act at every level of pain. So sometimes till date, there is a big opioid dependence problem in the US, where maximum opioid users are prescription users, where prescription is rolled out for pain. Let's look at central sensitization of pain. A suprasegmental sensitization can be of peripheral pain. Let us say I have a low back ache. And the low back ache is associated with a lot of disability in my life. Like, for example, I have to give up work, I have to give up play, I have to give up travel to my friends. Every time I move, the pain increases, so I give up my favorite activities. So there's a lot of supra, and I'm so afraid that once again that spasm will happen. Once again, I will be put on bed rest. That I hardly move at all. I hardly try certain positions. So my life has become very restricted. All these things promote suprasegmental central sensitization of pain. Not only that, even at a biological level, there is preference to pick up the nociceptive stimuli. So what happens is that my fibers may be perceiving different stimuli like pressure, like temperature. But because the same pathway gets activated over and over again, every stimuli, a pressure stimuli, a touch stimuli will be perceived as a pain. A suprasegmental sensitization can originate in the brain, like chronic widespread pain, like painful symptoms of depression, anxiety, like fibromyalgia, where there may be no peripheral nerve damage. So let's look at peripheral sensitization and sensitization that happens because of some peripheral damage and without peripheral damage. In peripheral sensitization, there is physical damage that occurs at the peripheral site, causes an inflammatory response, and it leads to an exaggeration and extension of pain response. Essentially, there is a stimulus required and then the pain is. In suprasegmental central sensitization, physical damage occurs at peripheral site. There are neuroplastic changes again at dorsal horn causing constant firing of neurons. Again, a stimulus is required, but the pain felt is much more than the stimulus. For example, the phantom limb pain. And in central sensitization, there are just neuroplastic changes in the thalamus and cortex without any physical damage. And there is a maintenance of a painful response without stimuli or sometimes very, very minor stimuli. And this again is like physical symptoms of depression, anxiety, fibromyalgia. Now, interpretation of pain is also very important. So, amygdala plays a part in emotional and affective response to pain. Pain has a very strong motivational response, a fear response. Hypothalamus is involved in the corticotropin response to pain. The periaqueductal gray matter is the center for pain modulation, involved in aversive and defensive pain behaviors, like avoiding any movement because it may worsen pain. Basal ganglia again may be involved in cognitive, affective, discriminative aspects of pain. Again, cortex is the ultimate site of any perception. And therefore, it can be a potential for conscious activation of descending pathways for pain modulation. And probably that is how biofeedback works. That through thinking, through cognition, you can modulate how you perceive a particular pain. So let's look at norepinephrine. Norepinephrine essentially modulates the descending pathway and causes inhibition of pain. And a relative deficiency may cause a deficient norepinephrine inhibition and may lead to increased pain. Pain can be at any side, stomach pain, back pain, muscle joint pain. One of the good things done by DSM-5 is that when it comes to somatic symptom disorder, they have reduced the need for medically unexplained symptoms. So whether the symptoms are medically explained or unexplained, they may still have emotional correlates. They may still have the same predictors of pain as unexplained symptoms. So that I think is a very beneficial move. So basically, the descending pathways start from locus ceruleus. And let's look at the various things that work on it. Antidepressants like norepinephrine reuptake inhibition can increase noradrenaline available to cause the inhibition of pain. Gabapentinoids can activate locus ceruleus. Valproate and other antidepressants can improve again the locus ceruleus function, causing the norepinephrine release and again causing chronic pain. Let's look at alpha 2 delta light. So, just as pain perception at the level of the axon, ultimately, how is the pain signal carried from one axon to another? It is through the sodium and calcium channels. And the increased influx of calcium channels is what is more responsible for any kind of nociceptive pain. So, if we can block the calcium channels and the sodium channels, they cause a relative reduction in pain. And this is how probably all valproate, carbamazepine work. This is how verapamil has been used as controlling pain. Not only that, I think our alpha 2 delta ligands, like the gabapentinoids, gabapentin 3 capsules, they also work on these voltage sensitive calcium channels. And what they cause is that they reduce the calcium. They reduce the calcium channels that have increased and therefore a hyper response over a period of time and reduce the pain response. So this is how it is shown that excessive painful stimuli, and central sensitization. Again, the block happens at a peripheral level, so it says peripheral plane, but we also work at a central level. So at all levels, the calcium channel, the axonal firing in response to the pain stimuli is going down. This is how this will work. It will work in a diabetic neuropathy pain, and it will also work in a completely central. Let's look at how serotonin works. So basically, serotonin 1A receptors are what are important. And serotonin 1A autoreceptors work as self-inhibitory. So if the serotonin increases, it will go and block the autoreceptor and it will reduce the firing. But post-synaptic HT1A receptors, what they cause is they decrease the release of nociceptive neurotransmitters in the dorsal horn of spinal cord. Not only that, these are interfered with GABA neurons, interneurons. So therefore, even glutamate receptor, NMDA activists like topiramate, etc., may act on these GABA interneurons, and via the serotonin pathway, they may reduce the nociceptive neurotransmitter. So opioids are actually, other than their action directly on the opioid receptor, they also have an action on the GABA interneuron, causing, they block the GABA interneuron. So the inhibition that the GABA interneuron causes to the serotonin circuit reduces, and more release of this thing, anti-nociceptive neurotransmitters is there, which is why almost all antidepressants, not only those with a norepinephrine content, but even something as simple as escitalopram, which is purely serotonergic, may have a pain relief. Our triptans work also on this thing. Now, other than that, there are inflammatory mediators of pain. So we know that glial inflammation happens at the level of neurons. And a newer molecule called PEA, palmitoyl ethanoyl amide, it is a nutraceutical, is supposed to work on neuroinflammation. How it works, we don't know. It's not very clear, but it has some role in working on neuroinflammation. So now, but pain is not just pain, as in what happens in the brain. And to all patients, if we give the same cocktail of, let us say, pregabalin, some calcium channel blockers, some antidepressants, the response to pain is not the same, because every person's personality and his behavioral response, his emotional response to pain is different. So what do we tell the patient when they come with pain? To begin with, we acknowledge that yes, you have a lot of pain. And I think that acknowledgement is in itself beneficial because it forms the first rapport with the doctor. Usually what they've heard from most other physicians is ये नाटक है, कुछ भी नहीं है, इनके सारे reports normal है, attention seeking behavior है, and they are probably tired of hearing this over and over again. Okay, so we say that yes, you're suffering from a pain disorder, there's severe pain. We have to tell the relative that this is not acting. This person is not feeling an illness. The pain that he experiences is real. Okay. Then they say that what happens? कि यहाँ पे सारे reports तो normal है. So usually how I tell the patient is कि समझिए यहाँ पे मुझे दर्द हो रहा है. अब यहाँ का एक्सरे, सोनोग्राफी, सीटी स्कैन, ब्लड रिपोर्ट सब नॉर्मल है. तो यहाँ से एक नस जाती है और वो नस दिमाग तक जाती है और दिमाग सिग्नल कैच करता है. तो या तो उस नस में डैमेज हो सकता है या दिमाग के सिग्नल कैचिंग एबिलिटी में डैमेज हो सकता है और हमें पेन यहाँ महसूस होता है. तो प्रॉब्लम है, लेकिन जहाँ का टेस्ट किया जा रहा है वहां का प्रॉब्लम है. I think with that, with a simple explanation in the patient's language, it helps them. We also acknowledge that efforts at pain reduction have failed. So it is good to tell them that actually there is a possibility that your pain may not completely go. We'll try and reduce the pain, but it may still be there. So we shift the goal of treatment from pain reduction to improvement in function. That forget the pain, even if you have the pain. There are people who live with cancer. But even if you have the pain, can we have pain not dominating every aspect of life? For the patient, the goals of treatment are that we learn to live with the pain. We resume normal social, vocational, recreational activities. Reduce medicines like NSAIDs or any other tramadol, etc. Live an independent life, do things that are enjoyable, and work on depression, anxiety, and pain relief. So, principles of treatment of pain disorder is that pain is a four-letter word. Let's not utter it. Let's not think about pain. Let's not discuss pain. Let's not investigate pain. Let's not seek treatment for pain. Because, like I said, our realities, our subjective realities are very different from how other people will perceive reality. So let us say I buy a brand new Maruti and I drive the Maruti on the road. My chances that I notice another Maruti are a lot. When I come back home, I may tell my family that, you know what, Maruti is a very successful car and I think white is the best color. That may or may not be the truth. But essentially, what happens is to patients with pain, their narrative, their self identity, everything, their life becomes revolving around the pain. And this pain becoming the center of your life is essentially what we need to take away. That pain is just one of the symptoms. There's more to life than the pain. So don't allow the pain to interfere with any of the activities. The more attention you pay to pain, the more it will increase, and lesser attention will decrease. We have to work towards stopping painkillers, removing prostheses, regular dynamic exercises. So there's a concept of um, proprioceptive acuity in pain. So proprioceptive acuity is like, let us say, रात को नींद में मुझे मच्छर काटा, I know कि मेरे right गाल पे काटा है, कहाँ काटा है, and I'll be able to scratch myself exactly. Okay, I'll not overshoot or come there. And this is at a time where my senses and my guards are really low. Even then, I will not make a mistake. But what happens is for these people, they probably generalize pain for every sensation. And even if a sensation is felt at a distance, they will localize it to the same area like chronic back pain. There is a problem with proprioceptive acuity. And it tends to improve with yoga, with dynamic exercises, with, let us say, exercises, mindfulness-based practices, where you become self-aware of the symptoms that the body is producing, or symptoms or any kind of sensation that the body is producing, and do not misinterpret everything as pain. Not only that, but if somebody has a chronic back pain, we tell them, let's move what you can. You can move the neck, you can move the fingers, you can move the wrist, you can move the knees. There are so many exercises that can be done, sitting, lying down, you can do abdominal exercises. So let's work on yoga, let's work on flexibility. Just because one area is paining doesn't mean that everything has to become zero. Attend individual or group counseling sessions and take part in some extracurricular activities. Now, there are a lot of recommendations that talk of TCAs as the first line agent for neuropathic pain, and they are my personal favorite. And let's look at TCAs. When you talk of depression and pain, some of the best recommendations are for TCA and SNRI. When you talk about pain, depression, anxiety as a cluster, again, TCA is venlafaxine and buspirone. Top the list. Pain, depression, cognitive complaints. Again, TCA is vertioxetine, mymantine. Maybe again are what is recommended. Pain, depression, sleep-related disturbances. TCA is mirtazapine, gabapentin, pregabalin. Pain and fatigue. Levomilnacipran, nortriptyline plus bupropion combination or modafinil. Inflammation, again TCAs, there's some role of NAC, some role of EA, but most of these are nutraceutical molecules with a limited effect size. And IBS, again TCAs. So when we talk about somatic symptoms, TCAs form. So I think TCAs were our molecules, but we are sort of using them a lot lesser than we used to use them in the past. So there's a very strong case for pain in TCAs. Non-pharmacological therapies like exercise and yoga, acupuncture has a lot of data on pain. Then transcutaneous electric nerve stimulation, occupational therapy does wonders for pain. CBT, hypnosis, biofeedback all have a role in it, and maybe even massage. Now, basically, there are two models of CBT. That one is the fear avoidance model. Fear complicates things. And acceptance of pain that there's good and commitment towards functional improvement. So the basic premise is that while pain hurts and it's the struggle with pain that maintains the pain and causes suffering. So we don't have to control the pain because efforts to control pain may be maladaptive and they may have unwanted side effects. So essentially, what happens is that most of our patients, they hyper-focus on body sensation. Through mindfulness, we reduce this hyper-focus on one kind of it. They have a catastrophic misinterpretation. So if there's a pain, they will think the worst possible outcome. They almost start having a lot of anxiety around any body sensation. So what they try and attempt is they try and attempt kind of vigilance for any body sensation. They try and control the body sensation. They avoid worsening of the body sensation, therefore avoid any movement. And at all costs, they want to avoid experiencing the body sensation. And through the CBT model, what we tell them is that this fear of bodily sensation itself is an unrealistic fear. And as a result, life is limited by attempts to avoid and control. So a person lands up feeling very anxious, very depressed. I think the CBT focuses on these cognitions and these behaviors. I'll end with this quote of Haruki Murakami: pain is inevitable, suffering is optional. And thank you.
Thank you so much, Dr. Kiran, for the wonderful presentation on the pain. And we learned many aspects of pain with you. And I was surprised to see so much of our medications in the management of the pain. We know, but to witness and to see in literature is something else. And as I completely agree with you, that pain is a strong motivation in a different sense. We all try to avoid pain, and that works the survival of the organism, I think. Very nice and wonderful, concise presentation, I would say. I will take the questions or comments from other people also. I would like to add here, and can you show me some lightness on that? As you was telling in the presentation, the basal ganglia is very important part in modulation of the pain. So technically or logically, our SSRI should be working on that to alleviate the pain, or instead of SNRI, which you have said, duloxetine, pregabalin, alpha ligands, and all those things. Other than hoping for that, we have seen in clinical practice sometimes atypical antipsychotics give a good relief in the pain. And I'm talking about the chronic pain. Mostly lower back pain. Along with the SNRIs, we give small dose of antipsychotics also, and they work.
So I totally agree with you. So there is the 5-HT1A receptor. And 5-HT1A receptor actually works on serotonin transmission and actually causes anti-nociceptive release of anti-nociceptive neurotransmitters. It can be activated via SSRIs. Even our atypical antipsychotics act on the 5-HT1A receptor. Besides, both these reduce the anxiety and the obsessive component around pain. Even at the cognitive level, probably how pain becomes centralized because a person keeps obsessing over pain also reduces.
So we have now some questions for you also. So do you think there is a role of RTMS in pain disorder? Dr. Shagun Saini asks, and she congratulates you for the wonderful presentation.
Thank you, Dr. Shagun. I have very little information on RTMS, and I've heard of RTMS in depression, never worked with RTMS. So I think that we have a lot of seniors here. They would be able to enlighten us on role of RTMS. I have no idea whether there is.
Our president, Sir Dr. Sunil Mittal, will be more the ablest person to tell us about the RTMS and the pain. So I think Sir is not here at present. Sir, are you here? So I also have not much experience about the RTMS and the pain, but logically, if it works on basal ganglia and thalamus, then yes, it should work. There are some studies going on, but I don't think there's any conclusive evidence coming out about the RTMS and the pain. Anecdotal events, evidences will always be there, case reports. So Dr. Imran Ali Shevzi asks you, ma'am, your comment on the role of coenzyme Q10 and L-carnitine in the management of chronic pain and cramps.
The coenzyme Q10, I don't know much about, but L-carnitine I've been using regularly, not for pain, for depression, as an add-on for depression, and specifically fatigue-related symptoms. I find it very good for fatigue. So as an add-on for depression, we can add it. I have no experience in pain per se, but how effective it is. But it does have a role as a liver detoxification molecule. It can be used in alcoholics and things like that. So taking that, many patients are on NSAIDs for pain reduction. So probably L-carnitine may that way help liver clearance. In fact, that is also one of the reasons why NAC should be added, N-acetylcysteine. Because other than having a anti-inflammatory role in the neural glia, it may also work on reducing the NSAID dose. Depending.
Next. So I would like to add here, as you per in your slide, you said the one of the novel drug you discussed about palmitotic acid, EMA. So the mechanism where it is working is mitochondrial dysfunction, and in that area. So carnitine and coenzyme Q theoretically has a role in pain management because through that same mechanisms through which this palmitotic acid is working. So yes, but I think for the same efficacy or the effect you want in the pain management, you need to go to higher doses, a very, very higher doses that might not be cost effective for the person, but it has logically a role in that. Is especially wherever you find there's a mitochondrial dysfunction can be there and there's some disorders. So I think one of the most common question you can ask your patient, hey, this pain is running in the family or not? So if this running in the family, then you can say it's a genetic disorder for suffering from mitochondria. Then you can use carnitine in that sense, but not isolated chronic pain. So, and yes, you were very rightly said, it works in the nutritional benefit and the liver things in the depression for fatigueness. Ma'am, so many questions are coming up for you. So most of the people have listened to the webinar. That's a high list. Congratulations for you. So how effective
I think Dr. Mittal is here. We can ask him about RTMS.
Yes, sir. Sir, there was a question. What is the role of RTMS in the pain?
Right. So we, one is of course the, let's say the literature that exists. And the second is our practical experience with RTMS. So one, that there is literature to show that in chronic pain, neuropathic pain, RTMS might benefit. Though it's not as robust a benefit, if you look at the statistics, as it may be for depression or OCD, where it's rarely indicated. So it may work in two ways. One is it may help relieve the associated depression, the anxiety. So that is one part of it. And the second is directly working on the pain pathways. and it can help in neuropathic pain. We have used it in neuropathic pain in a few, say a handful of patients, because there's not something which we go out and promote, but people seek themselves, and the pain may not go away, but the what can I say, the perception of pain, the response to pain, that has undergone a change. The pain still may happen because like Dr. Kiran said, the pain may be experienced differently, whether it's burning, numbing, paresthesias, as you may say, and they are the same common pathways. So yes, as an adjunct to other treatments, RTMS would be worth a try in chronic pain conditions and neuropathic pain.
Thank you, sir, for the insightful. We were not very much aware of the RTMS, so thank you very much, sir. So, next question for you, Dr. Kiran, and from Dr. Jatin Daman, how effective is valproate for the pain?
So definitely valproate has a role in migraine prophylaxis. So there it is used. But other than that, we are not really using valproate in other neuropathies like how we're using carbamazepine. And second line from carbamazepine is oxcarbamazepine or lamotrigine. Other than that role in headache per se, valproate hasn't been used so much in pain conditions. Other than this, the literature is silent on it. There is not much role, I think, other than again, topiramate also we're using specifically for migraine, but they're not using for.
Yes, totally agree with you, ma'am. And we have many better alternatives than valproate for the pain. The side effect profile, adverse effect profile will be much better in other drugs. Sir, your insight upon valproate and the pain?
You're asking me?
Yes, sir.
Okay, right.
So, let us.
Yes, let's get a discussion going on that. Yeah.
Yes,
So valproate, like has been said, there could be again the whole question is at what sort of pain. Yes, one could plug in by using anticonvulsants for pain, and the most common ones being used there are carbamazepine and oxcarbazepine, especially in neuropathic. Of course, in a different sort of pain like migraines, valproate does find effectivity. But if you're looking at fibromyalgia or other chronic pain conditions, it could be an add-on, but I really don't know whether it's going to be one of the primary agents that one is going to be using. I have not personally used much of valproate other than when there are the mood conditions. Perhaps Dr. Kiran could, if she's reviewed literature on this, could add something.
So I only know about migraine and valproate. Even in neuropathies, valproate is not being used.
So
and I think from
yes,
our side, what we add to pain management is the behavior management of pain. Because if that behavioral management doesn't change, the outcome of pain. Because by the time a patient has come to us, they have gone to all neurologists. And the neurologists have given a cocktail which is stronger than the cocktail we are going to give. They've gone up to 1800 mg gabapentin. Those are not doses that we use normally. But so essentially what I feel is that working on the depression anxiety is where we sort of succeed. Depression, anxiety, other pain related behaviors, shifting the focus from pain control to improving life.
I think that's very well said, because see, the response to pain, one is the actual physiological aspect of pain. Let's say there is a neuropathy. It continues to exist. There is demyelination. It continues to exist. Or but then the response to pain, one of course one can say is that the habituation, that is one part of it. The second is the behavioral and emotional response to pain is something, that's why as psychiatrists we are speaking about it. That is not something just left to a neurosurgeon or a neurologist or a surgeon or an orthopedic surgeon. The response to it. So I would feel that yes, the behavioral management of pain and what Dr. Kiran presented in her talk today, those are important areas in pain management, other than just the pharmacotherapy of pain, where you plug in, things work, things don't work, and you go on to cocktails and very massive dosage, which you might come across some prescriptions. And then plugging in with so many other things, supplements like we have spoken about, whether it is an acetylcysteine as an anti-inflammatory, and people are on medication as for hepatic protection because of the NSAIDs persons may be on. And then, of course, the response to pain is something that can be worked upon. Let's not forget the response to phantom limb pain is something we are aware was worked upon. I'd share something from where my own personal about this is about 37, 38 years ago. I had an accident and I live with 2 slip discs actually, and the third is also almost herniated. And it was a terrible experience. I've had trigeminal neuralgia as well, but this was terrible and disabling. Lying on bed, having pain, you can't even walk to the toilet, you can't cough, you can't sneeze, if you can't take a deep breath, and it was terrible. But then you get all sorts of painkiller reliefs, and then the spinal injections of steroids and so on. But then finally, it's 38, 40 years. And what has happened is my own response. I'm talking from a very personal experience. The response to it. And 10 years after this, I was trekking with 20 kilograms on my back. So there's a behavioral change. Working on my back, my exercises, my response to it. And that is something which came as an insight. Okay, I've got to live with this condition. It's a mechanical condition. It's not going to go away. Right. So those are the sort of things that one can work with. And any one of us who's had a chronic pain condition knows that our own response can be modulated, modified. Coming from there, that I would still have my paresthesias. I would still have what may be classically called a sciatic sort of pain. But then that's it. So I would not say one can be dismissive. I would not say one can trivialize pain experiences. And they have to be seen in the person's own life reality, what it means to that individual and that family, how disabling it is. On the other side, I've had a patient, just to put pain in context, somebody who was an army officer who had received bullet injuries, who also said he had had appendicitis, and who also said he had had trigeminal neuralgia, and he was depressed. And he said that this pain or depression is something which I can't bear. I can bear all that pain, but this pain or depression is something I can't bear. So it's the response to pain, for whatever reason that pain is arising from. And then, of course, addressing that pharmacologically, addressing that through rehabilitative measures, and then, of course, altering the response to the pain, behavioral and emotional.
Pain is a good teacher, sir.
It is. And I think for psychiatrists, it's a good link between the biological processes and although I wouldn't say that one should be believing in the schism, the dichotomy, but the psychological, social, and the biological processes, they all come together when it comes to pain.
May I comment something? We have, I think, all of us, you may agree with it, that many of our patients who come, actually, whatever sir said about psychological or physical pain, come to us and they are already on treatment with good number of medicines. Particularly pregabalin is one of the medicines which is frequently being prescribed, although by non-psychiatrists, more of even neurologists, physicians, surgeons, everybody. He puts in a prescription of pregabalin in patients of pain. It may be psychological pain. He might actually have severe depression, PTSD, or whatever. So, what the senior colleagues here are? What's your experience regarding pregabalin? How much it's being used in your setups, and what's your take, Dr. Kiran, on this?
So my feeling is that pregabalin may be an add-on medicine. It does reduce some form of neuropathic pain. It does reduce anxiety around pain. It often is not is the main medicine. The main medicine is a TCA. I've put up a case very strongly for a TCA because TCA, while it manages the pain very beautifully, it also manages the depression, the anxiety, the sleep-related complaints, uh, other complaints associated around pain. So pregabalin may be effective, but like I said, alone or now they have this combination of pregabalin, duloxetine, lot of substances are coming with it. It adds to some sense that we would want to add a duloxetine, we would want to add a pain, a norepinephrine component.
Yeah. I think it's already 9:02. If there are no other comments or questions, sir, chairpersons, before we go off, I request chairpersons and moderators to have their concluding remarks before we go to Dr. Manushri Gupta for a vote of thanks.
Right. So I think we've had a very interesting presentation, very, very insightful and excellent presentation. Thank you, Dr. Kiran, for this. And it's insightful because, like we began saying that, and like how I remarked that it bridges the whole experience of physiology, neurobiology, psychobiology, the whole realm of it. And pain is something that we commonly see. Pain is something which is going to be there as long as human beings are going to be there. The TCAs or the SNRIs as relief for pain, as pain relief, is something that, like Dr. Kiran says, she makes a case for it, and I would second that. I would agree that there is a case for it because NSAIDs and the renal problems and the other problems that arise. So the take-home message is pain is here for real. People who suffer are for real. And as psychiatrists, we have an important role to play in pain management. And then for other remarks to my co-chair.
So that was a beautiful talk, Dr. Kiran. Thank you so much for that. As I said before in my opening remarks, that quantifying pain is very difficult. And over time, as Dr. Mittal has put up with his pain for more than 30 years, I think we develop a resistance to pain. We have a lot of celebrities also who have spoken about pain resilience and pain resistance over time, that we get used to the pain and then I think sometimes we even miss it if it's not there. The other thing that there's so many scales that try to quantify pain. I think the most common being the Wong Bakers with all the cute faces ranging from 0 to 10, but none of them seem to have any scale that actually quantifies psychogenic pain. So we would probably need to have a talk on all our malingerers, our pain resistant self harmers, and areas where we have psychogenic pain, and how do we deal with this pain, because they're already addicted. They've been to 1 million doctors. They come with 10 or 15 files of medication, already addicted to pregabalin. Have a patient who takes 800 milligrams of gabapentin twice a day, and also addicted to sleeping pills, chlorodiazepam, you name it. So addiction is a part of pain therapy. And as mental health professionals, we do come across people who come to us because we are last on the list, for help when people want to take help for pain. So they're already addicted. So we have actually another task before us to de-addict them and also deal with the pain. So there's also a lot of therapy that goes into this, cognitive therapy, and there are a lot of other therapies that can be used, particularly acceptance and commitment therapy. So I think this topic can go on and we can keep talking about this all night. But I thank you so much. I was just going to leave, and now the meeting is coming to an end, so I just thought I'll stay on. Thank you so much again. Thank you, Dr. Rukshida, for having me here as chair. Thank you, Dr. Sunil Mittal, our wonderful moderator, and Dr. Majid. All of you, thank you so much, and it was great being here.
Thank you. So, taking from here, I think the take-home message, what I got from today's presentation is that pain is biological. Pain perception can be modified, and you can develop resilience to the pain, and life is beyond pain also. So thank you, Dr. Kiran, for the wonderful presentation and giving us insightful discussion about giving the platform from which we can have an insightful discussion on all the aspects of pain. Thank you so much, Dr. Kiran.
Thank you so much. Nice.
And thank you, Dr. Tiwari, for this wonderful moderation.
Thank you, sir. So over to you, Dr. Manu.
Yeah, thank you, sir. So the last one to speak, but I can have the everything has coming filtered to me, and I have the best view from on the house. I would like to come to Dr. Purnima's point, madam. You made a very important point that sometimes we are the last ones to, when the patient visits different doctors, we are the last in the line. But we as psychiatrists often can provide the first solutions to chronic pain, psychosomatic pain, with our therapies and of course TCS, as rightly pointed out by Dr. Kiran. So I think that is the take-home, one more take-home message. I would like to thank our chairpersons for today, our always elegant Dr. Sunil Mittal sir and Dr. Purnima Nagarajan. This was my first interaction with you, madam, but I think it was a very fruitful discussion we had. Thank you to Dr. Manu Tiwari for moderating this session very well, sir. All thanks to you. And I think you put in, you added to the speakers' points very, very well, sir. I heard your points, and the points that you added were actually complementing what Dr. Kiran said. Our special thanks to Dr. Kiran, Shandilya, and this was a wonderful presentation from physiology to pathology, then psychiatry. I think it was a 4.5 years of MBS rolled into 1 hour session. So thank you, Dr. Kiran, for that wonderful session. I would also like to thank our office bearers of IABP. I think this first Friday CME we were the second society to start in India after the Thursday musings of the IPS Odisha branch, and we are going strong. And I'm especially glad to look back at the topics that IABP Executive Committee has chosen for Friday CME, all purely biological, and we are sticking to the agenda given to us. So thank you, Dr. Rakshida, and Dr. Aleem, our Vice President, Dr. D'Souza, and all the office bearers who have been instrumental in carrying this forward. So thank you. Have a great night. Have a lovely weekend. We'll come again next month with a new session of Friday CME by IABP. Thank you, sir.
Good night, everybody.
Good night. Good night, sir. Good night, ma'am.
Good night, and thank you very much, everyone.
Did I forget Dr. Majid, sir? Sorry, sir.
No, not at all. You don't need to thank me. We are one. Don't worry. Don't worry. I think
he holds
Rukshida needs to be
together.
specifically mentioned.
Yes.
Yeah, I'm always at your service, and we are together. It's a team effort always. No need to thank.
And since we are talking about the missed things, I forgot to thank Dr. Purnima. So my thanks for this.
Thank you to each one of you. Thank you so much. And thank you to Dr. Rukshida also, because she called me and she said,
yeah.
Everyone have a great evening. Okay.
Yeah.
Thank you. And yeah, good night.
Good night, everybody.
Good night. Good night.